Hello, everyone. My name is Komal Bajaj. I'm an OBGYN geneticist, clinical director of simulation, and chief quality officer within New York City Health and Hospitals, which is the largest municipal health system in the United States. People will often ask me, reproductive genetics, simulation, quality, I don't get it. Well, whether it's taking whole exome sequencing or how a team manages a crisis, for me, it's the joy of taking something that's relatively esoteric and making it palatable and sticky. And there isn't much that's more complex than a health system. I was really looking forward to joining you in person, but unfortunately, I had some last-minute leadership commitments come up and I had to pivot. Regardless, I'm truly honored to be with you today and connect with this wonderful community of practice working to uplift health and care for birthing persons and children in Tennessee and beyond. I'd like to thank Dr. Rolanda Lister and Ms. Brenda Barker for their kind invitation to talk about practical strategies to integrate simulation and debriefing into a quality and safety agenda. Throughout the talk today, you will see this icon, and I'll be referencing many resources which will be available to you at a QR code at the end of the talk. So when I say simulation, we each might conjure up a slightly different image in our mind. Some with full body mannequins, others with virtual reality headsets, some in the clinical environment, others in a sim center. The strategies that we'll be discussing today are broadly applicable to all types of simulation and debriefing, high tech, low tech, interprofessional, or anything in between. Before we get to strategies, let's get the juices flowing. Turn to your neighbor and for 2 minutes, discuss what are the barriers to integration of simulation and debriefing into a quality and safety agenda. I'll join you back in 2 minutes. I suspect that there are plenty of barriers that you came up with, and there really are substantial barriers to integration of simulation and debriefing into a quality and safety agenda. So here's a fishbone diagram that describes some of those barriers. Let's start with people. There's really a need for training. Sometimes there are interprofessional silos that prevent simulation and debriefing from taking hold. And I found in my experience that there are sometimes limited linkages between folks that are considered quality and safety team members and sim team members. From a material standpoint, cost is an important consideration. I also think it's important to mention that sometimes the tech doesn't match what is needed on the ground. There's also a limited availability of diverse simulators. I recall an example when we received a multi-million-dollar grant in 2018 to address maternal mortality in women of color using simulation. And we couldn't find ethnic birthing prompts. After a lot of advocacy, we were able to convince simulation companies to create those prompts for us. We were the first in the world to have ethnic birthing prompts, but this continues to remain a challenge today. When it comes to methods, simulation has been rooted in education, and sometimes it's challenging to make that switch. The ROI, or the return on investment, can be difficult to translate to a balance sheet, and sometimes it's perceived as an add-on. Time, space, and distance can also be barriers to integration of simulation and debriefing into a quality and safety agenda. I'm hopeful that after the end of this talk, you'll be able to identify practical strategies to address most, if not all, of these barriers. So let's get started. The first strategy is to consider simulation as a means of study or a test of change, or both. Many of us may have had the need to integrate a hemorrhage cart or a hemorrhage box or something equivalent into the clinical environments. And here were some of the questions that we needed to ask ourselves. Which cart to select? What items go in the cart? How should we organize the drawers? What areas need a cart? How many are required? What's the best location? How should we train members to use the carts? And how can multiple team members use the cart at the same time? Also, after doing all of that hard work, are teams actually using the cart effectively? Turns out that simulation can be a powerful tool at each step, whether it's helping design a process, whether it's to implement the process, or to make sure that the process is working. And in fact, we've used simulation in all 11 of our labor and deliveries to do exactly that as it relates to hemorrhage carts. And as a result, we found, tremendous uptake of this important tool in hemorrhage care. And so if we tie this idea of simulation as a vehicle of study or test of change back to James Reason's Swiss cheese model, in which the risk of a threat becoming a reality is mitigated by various layers and defenses behind each other, simulation is a very effective way to probe systems. This is a really wonderful way to identify those latent safety threats or those holes in the Swiss cheese. It can also help optimize process design, improve culture through practice and debriefing conversations. And these are all examples of simulation as the test of change. And so it's important to think of simulation as a strategy that can really target all of these different layers, whether it's culture, design, or processes. I want to highlight this resource, which is the Pearls for System Integration Healthcare Debriefing Tool. There's a lot here on this slide. And again, the QR code will create a link to a free download. But the point here is that our community of practice has evolved enough that there are sort of tools to utilize during debriefing that can help probe the system, in a variety of different ways. Quality and safety legends Lamé and Woods describe simulation really as a flexible and what they describe as a pluripotent technique that can be used in multiple study designs in healthcare improvement research. And here you can see some of those outlined, whether it's projects themselves, qualitative studies, economic evaluations, effectiveness, or process evaluations. I encourage you to take a look at this work because it very elegantly describes the many different ways that simulation can be described. And so for those that are interested in publishing or presenting work, the Standards for Quality Improvement Reporting Excellence, also known as SQUIRE, guidelines, there is a simulation extension coming soon, really honoring the importance of simulation as both a vehicle of study as well as a test of change. Happen to be part of the steering committee, and that should be coming out within the next few months. The next strategy is to keep an eye on the literature because there are robust examples of impact that are already in the literature and are coming in faster than ever. And it's an interesting time because there are sort of traditional quality journals, there's simulation journals, and of course many professional society journals, including ACOG's journal, AWAN's journal. And so we're starting to see journals sort of publish simulation work in sort of different ways and flavors. And it's exciting to see that overlap continuing to expand. And I recall when I first started in simulation now, 12 plus years ago, it's really hard to find some of those examples. I'm going to share with you a few that we've used over the years to help garner buy-in as well as funding for our simulation work. The first, really, many are familiar with the example of using a simulation-based mastery learning curriculum around central line. And I want to highlight that this curriculum now, over the course of 9 or 10 years, has demonstrated impact at every level of learning evaluation. So when a simulation-based mastery learning curriculum around central line was deployed, those that took the curriculum had a higher self-confidence rating. Not only that, seemed like the curriculum helped them learn things. More than 93% achieved a minimum passing score, whereas prior to the curriculum it was 16%. There also were fewer needle passes. There was a remarkable 74% reduction in CLABSI, and this translated into $7 saved for every training dollar spent. Truly remarkable. Within obstetrics, Tim Draycott and team have published over the years their remarkable work, utilizing interprofessional simulation to address obstetric emergencies. I wanted to highlight this recent article where they did a cost utility analysis of simulation training for obstetric emergencies. And this national implementation of this well-established multi-professional simulation training resulted in over £1 billion in savings over 30 years. And what was also interesting in that work was that there was very strong evidence to suggest repeated and sustained training was the key to that savings over time. And this is just a remarkable example and how the community of practice has progressed in its understanding of the impact of simulation. Rose and Rose implemented a debriefing checklist across McLeod Health System after every OR case. Just truly remarkable, every OR case. They had recently implemented the surgical safety checklist and sort of used that experience to implement this debriefing checklist. Took 3 minutes, and the goal was really to focus on, reporting instances of harm or risks to harm. And they described their experience of 54,000 cases, of which 4,500 found a defect and 92 of them were critical. And here you can see an example of that checklist. And what was remarkable was that it took on the order of 3 minutes to accomplish this. And what you can see here is that over the sort of quarters, over 12 quarters, there was a remarkable decrease in 30-day surgical mortality. What's fascinating is that they started at a baseline rate of reporting, and as people got more comfortable, that reporting rate went up. It really just went up, and as those fixes continued to happen, the amount of reporting of incidents went down because there were sort of these debrief-driven improvements that had happened. So not only was there a substantial clinical benefit, you can see here that there was a remarkable increase in safety climate, where individuals after implementation felt that they could better speak up about patient safety concerns and that they themselves would be safe, feel safe being treated as a patient. Just remarkable work. The third strategy is to match tech to needs. And this is really a personal soapbox of mine. It's really tempting to purchase mannequins and simulators with a lot of features. And I have to say, simulation companies don't help the matter. There's a lot of focus on realism and sort of upskilling certain features about the mannequins. The challenge really becomes making use of all of those different features, maintaining the mannequins as they experience wear and tear, and ensuring that the simulators continue to meet evolving needs. I'll give you the example of teaching injections. The simulator on your left costs 39 cents. It doesn't take much room, it's disposable and easily replaceable. The simulator on the right costs $800. It does come with more features such as venipuncture. And so it all depends on what you really want to do with it, not just today, but over the course of months and years ahead. Translating this to our own experience with health and hospitals, in our early days, we purchased some higher tech mannequins whose functionality honestly didn't get used because we were growing our own expertise and really understanding how best to design an obstetric simulation program. And as a consequence, some of them sat in closets for longer than we would have liked, or were used as really expensive birthing pelvises. And so since that time, this is a map of our health system, which has 11 labor and delivery units, births, 18,000 births a year. Since that time, we've developed a wide range of programs, and we work with simulators of all types, including low tech, high tech, hybrid models, simulated patients, and virtual reality. But it took that time to really understand, what features do we need, where to spend our money. And so, I want to draw your attention to this resource by the International Association of Clinical Simulation and Learning. This document really describes, sort of how to build a simulation-based experience and prompts individuals to consider how best to align modality with objective. The next two strategies I'm going to pair together: harness emerging accreditation requirements and examine existing quality safety structures for simulation representation. This is a screen grab from a document from the Joint Commission, which was published in 2019, which outlines their new standards related to the provision of care, treatment, and services for maternal safety. And in that document, there are two standards. This document discusses hemorrhage as well as hypertension. And these requirements apply to sort of both of those type of emergencies. It asks organizations to provide role-specific education to all staff and providers. And it also requires that organizations conduct drills at least annually. Like most things in the Joint Commission, there are these standards that are set, but there's a lot of room for interpretation based on local policies and procedures. Veronica Lerner and I wrote a little bit about our experience getting ready for these standards in an article recently. And what I really want to highlight is that this is a really important opportunity for those folks who are working on, obstetric emergencies, to partner with simulation folks, to partner with accreditation folks, and have conversations about how best to meet these standards, and equally importantly, meet these standards, but also meet the needs of our staff and our patients. And so as you're thinking about your existing quality and safety structures for potential simulation involvement, I want you to ask yourself a few things. How close to the current quality and safety table of organization does simulation exist? We're very fortunate that in our health system, simulation is perceived to be a quality and safety tool, so that when there's a pain point within our health system, simulation is one of the many different strategies that is discussed. That isn't always the case. And so look to your sort of organization and see if there are opportunities for synergy that don't currently exist. I also want you to consider our quality and safety related grant proposals incorporating simulation expertise. This is one important way to make sure that everyone's speaking the same language and sort of chasing after the same goals. Are there opportunities for cross-training? I find myself as a simulationist and healthcare quality expert really spending a lot of time talking with different groups about, fundamentals of both areas: debriefing, approach to performance improvement projects. And so, I urge you each to consider, if your folks are really steeped in quality and safety methodology, is there an opportunity for them to learn a little more about simulation and vice versa? Do the agendas of quality and safety meetings include simulation-related topics? And in what cadence? I don't think it's necessary for simulation to be reporting out at every meeting, but perhaps, and maybe perhaps that is the case, that it is necessary at your institution. But quarterly, semi-annually, do they attend the meetings, whether it's departmental or local or regional? Consider, the composition of your meetings as well as the agendas. And do your trainees have exposure to both quality improvement and simulation? Certainly now, both in, various training programs, nursing, physician assistant programs, even in medical school training, folks are using simulation more and more for training these professionals for practice. And so, really looking to grow individuals who have an expertise in both. The last strategy to consider is clinical event debriefing as a foothold for simulation. I just want to remind everyone that really, the AHRQ defines debriefing as a dialogue between two or more people. And oftentimes debriefing, occurs after very severe events, but we really want, these conversations, to be harnessed as an important opportunity for learning and for culture change. And just want to impress that, whether there's a clinical event debriefing or not, there is debriefing that happens all the time, whether it's in the call room after a shift or at sign out or on the ride home, someone's thinking about what happened during the day. And above all else, debriefing is really just a reflective conversation. And so, being able to really capture all of these beautiful ideas and things that are occurring, I think is really, really important. And what we're finding is we've implemented clinical event debriefing programs across our health system, is that their purpose is really trifold. It's to improve culture, right? By having a shared mindset and discussing sort of things that are occurring, both maybe unfavorable events, but just other events in general. It's a real opportunity to crowdsource opportunities for improvement, or those gems are really, really important. Made a ton of changes based off of what we're hearing in debriefings. And what a powerful thing if folks, know as you move back to participants that, wow, because of this thing that I said in debriefing, this change was made. And then certainly even prior to the pandemic, but now, more urgently, being able to tie in these conversations as a way of support and wellness is crucial to, how we move forward. And so we recently presented a workshop at the Institute for Healthcare Improvement on clinical event debriefing. And if you think about debriefing as a way of, people may not be interested in simulations in the clinical environment right off the bat because it requires, expertise and training and time, all of these barriers that we discussed. But as people get more in tune with debriefing conversations, it's likely, and what we found is that people are able to layer in some of that simulation work paired with a debriefing, and there tends to be a less barrier to entry. So I really encourage you to ask yourself when you're sort of either considering a clinical event debriefing program or expanding a clinical event debriefing program, who are your stakeholders? And I really hope that they're both quality and safety folks and simulation folks. And there's no one way to debrief. And so what framework works best for your environment and who will be those champions? Really what we found is that, humans are humans. We are all, here in healthcare to, serve our communities. And so really anyone can serve as a debriefing champion. Thinking about psychological safety and sort of where this information might go that's learned from debriefings is crucial. And that really speaks to what clinical events should be debriefed. You may want to start with not the most severe event. And then, as important as the debriefing conversations themselves is how will you collect those learnings, act on those learnings, and then close the loop with staff regarding all of that, impact that they've had. I think it's a remarkable way of sort of changing culture. And so here are sort of the strategies that I consider, based on our experience in New York City, as crucial to integrating simulation within a quality and safety agenda. And so I'd like you to think about what's one concrete action that you can take in the next 3 months to integrate simulation and debriefing into your quality safety activities. I'm going to ask that you turn back to your neighbor and again, spend 2 minutes together, really identifying one concrete action you can take in the next 3 months. Two minutes flies by. I really hope that over the course of the next 3 months, some of you are able to implement that concrete action. So as promised, here's the QR code with the resources that are discussed today. I will also share my slides with the program organizers for anyone who's interested. I also encourage you to connect with me on Twitter. My handle is Komal Bajaj MD. Or email me if you have other things that you'd like to chat about. We need to do better for the birthing persons and their babies in our communities. And I have to say that recent CDC data demonstrating an uptake in maternal morbidity and mortality really means that we need to think differently about our approach. Some things are working and others are clearly not. And while simulation and debriefing won't be the only solution, they will definitely be part of the solution going forward. And really, you know, there's so much that we've learned from this pandemic. And I think we have a real opportunity to change not just how healthcare is delivered, but also how it feels to deliver that care. And you know, the time is now, and we really can make meaningful change. And I look forward to making that meaningful change with all of you together. And now we're ready for some questions.